Hello, and now we're entering the fourth and final installment in Chapter 14, Part 2B on cardiovascular physiology with emphasis on the heart. Last time we finished, I was talking about the electrocardiogram and the different elements of the electrocardiogram. That is to say, the P wave, the QRS complex, and the T wave. Yes, we have segments, and those fall in between the waves, and then we have intervals which actually include the outside waves. So like for instance, the PR interval includes the P wave and then ends at the QRS complex. The QT interval includes both the QRS complex and the entirety of the T. But the segments, on the other hand, are in between these wave forms. And again, this is a lead 2 wave. The waves will look different based on the frame of reference, if you recall our vector phenomenon. And the waves will also look different if there are any differences in position or conductivity that occur in the heart. And that's what we use for diagnostic purposes. Great video on Khan Academy. Please do take a moment or two if you want a little more explanation about the lead 2 rhythm to take a look at this. It's only 9 minutes long. There is a little bit of some time stuff in there, but honestly, get at the stuff that you see me talking about, and hopefully maybe in a slightly different light, and will help it stick a little better for you. Okay, so let's start putting pieces together. We've talked about the electrical events. We've alluded to systole and diastole, that is to say contraction and relaxation respectively. We need to keep progressing, though, into the larger picture, the full-on system of the heart, what I would call the deluxe pizza, because you've got a bunch of different things going on all at once. So we're going to relate the electrical activity and start putting in physical activity as well. One note, you'll notice the 141 down here on the lower left. I'm going to, every few slides, put a time marker so that if somebody is having trouble, I was speaking with somebody yesterday about a previous PowerPoint presentation. She'd been downloading the PowerPoints, but I think we have a version incompatibility or something. I'm not really sure, but she can't see this red pointer that I am circling around the figure right now. If you can't see that figure, then maybe it would be a good idea to go double check. If you can't see that pointer, it would be a good idea to go double check the YouTube video, and that's what this timestamp is going to show, so that you don't have to watch the whole video and try to find it yourself. I'll try to put those timestamps in there so that it makes it a little easier to find. But we're going to go through this sequentially. We're going to start putting the electrical events with the physical ones, and then eventually we're going to talk about volumes and pressures and some other things. So let's start at the beginning. Thankfully, this time it's at the 12 o'clock position in the previous diagram, with the onset of a cardiac cycle, if you will. This time, right at the beginning, right before we see the SA node fire off, that is a period known as late diastole. Late diastole is when both the atria and the ventricles are relaxed, and that's actually almost, 2/3 of the time in the cardiac cycle. It's quite a long time, relatively speaking. So in the next hour, your heart will not be beating for 40 minutes. In any case, we have that action potential fire off from those autorhythmic cells. Remember, that's autorhythmic cells in that node there. And that leads to a fast signal going to the AV node through those internodal pathways. But it also has a slow signal that's spreading, relatively slow, that's spreading through the atria from the base towards the apex. That's what registers as the P wave, that atrial depolarization. Note that this is not atrial contraction. Okay. In fact, there's a story I have. When I was in college, I was lucky enough to shadow a cardiothoracic surgeon, and they were doing open heart surgery, and I could see the electrocardiogram and I could see the heart beating in the chest at the same time. And you would see the beep, you'd see the rhythm on the screen of the electrocardiogram, and then you would see the heart squeeze. I mean, there was a tangible difference in time. Beep squeeze, beep squeeze. So keep in mind that all of these electrical events are not directly associated with physical ones. I will point out the period of time where the physical events are likely to occur, but nothing in the electrocardiogram is physical. So we complete the P wave. So we have a wave of atrial depolarization that has spread right down to the atrioventricular interface. And it turns out there's actually a lot of connective tissue in here that prevents or should prevent the action potential from spreading down into the ventricular myocardium. That would be nearly disastrous to initiate an action potential right here in the ventricle, because you know what would happen is that the depolarization would spread this way, contraction would go towards the apex, that would actually squeeze away from the outflowing arteries, and that would lead to a prolonged contraction period and perhaps damage to the myocardium. It's not a healthy thing to squeeze from the base to the apex in the ventricles. So there's a lot of connective tissue between here that prevents those action potentials from spreading down into the ventricles directly. They should be coming through the AV node and the bundle of His. We've completed the P wave, so we've finished that spread of depolarization. And during that PR segment, if you will, or shall we say PQ segment, because that's probably more accurate, okay? PR segment, in any case, that would be the time that atrial contraction is inferred. Okay? Would be sort of in the latter end of the P wave, right up until somewhere around P or Q or R. You can see that the contraction overlaps, goes beyond that PR segment, if you will, and kind of spills over into the QRS a little bit. Now, the QRS complex is a combination of the firing of a signal down the bundles of His and the bundle branches. So we do see a very minor, or we will occasionally see a very minor. It's not always registered on an electrocardiogram, either because of the sensitivity or because of interference from other waves. There's all sorts of possibilities why you don't see a Q. If you don't see a Q, that is not an automatic flag for arrhythmia. If you happen to see a Q, you see that nice QRS spike, that's probably enough for a normal rhythm. So don't get bent out of shape if you don't see a Q and an S every time. But if you should see that nice, healthy, narrow R wave, though. So during the Q, we actually have the rapid signal being transferred after the delay in the AV node down the bundle of His, the bundle branches, and then you'll start to see Purkinje fibers. So now we're at the point where we're getting rapid signaling from the AV node down the bundle of His and the bundle branches and the Purkinje fibers, and that registers as the QRS complex. We just see Q and R here. And again, don't get bent out of shape if you don't see a Q and an S in the complex. What we need to see is a nice, healthy, narrow, peaked wave, spiky wave like so. That's the real key, not the Q and the S, but the R, if you will. So let me move on to the next slide and I'll finish off my thought here. So the QRS complex is basically ventricular depolarization. It should be rapid, it should have a nice narrow, and it should have a relatively large displacement on the electrocardiogram. If you start to see it widening, if you start to see a double tip, there are some reasons behind that, and then we'll talk about that a little bit in arrhythmias later on. Nevertheless, this is ventricular depolarization. It is not ventricular systole. And one more time, don't get bent out of shape if you don't exactly see those Q's and S's. It's more about the narrow, spiked peak of the R wave. So during the ST segment, which is basically somewhere around in here going to the beginning of the T wave, that infers ventricular contraction. Again, you will not see, or you should not see, ventricular contraction on an electrocardiogram. Yeah, there are some physical reasons why you might see some sort of manifestation, but by and large, what you're talking about is something that's invisible to the electrocardiogram. And so during the ST segment, that infers ventricular contraction. ideally with ejection of the blood out of those outflowing arteries. So once we have finished depolarizing and contracting, we get this repolarization wave that manifests as a T. So you see a mild or sometimes significant deflection, especially in young people. When I hook them up to the electrocardiograms, you guys often have these huge T waves and everybody's freaking out like, oh my God, what's wrong with my heart? No, no, no. It's just that everybody's heart's a little bit different, and a young, healthy heart will often have slightly different electrical characteristics. But in that's a good point. The lead two rhythm that you see here is the average, adult rhythm. Younger people are going to have a slightly different rhythm. Sometimes older people have slightly different rhythms. There is variability here, and you can't get super granular about it. I know many folks want to gravitate toward sort of that granular analysis. There are appropriate times for that in electrocardiogram. Often that has to do with time, not so much shape. When you're talking about variability across patients, time you can get pretty granular. That would be a good time to focus on, but in this class we're not going to focus on that. So don't get too bent out of shape if if we do an electrocardiogram or if you get one of your own. I recommend it. You could just go get one if you can. I think you can go if you get you might be able to get one free, at the health center or something. But in any case, yours might not look exactly like this. But that T wave is the repolarization of the ventricular myocardium. And at the end of the T wave, we're now at a sort of a basal, voltage, shall we say. That's late diastole. And what's going on in late diastole is ventricular filling. We have the pulmonary arteries coming back or pulmonary veins coming back to the left side, vena cava. You're seeing passive filling during this time. And this is fully the longest period in the cardiac cycle in terms of time is late diastole. And that's when most of the ventricular filling, about 80 to 85%, maybe even a little bit more sometimes, occurs during late diastole. Every once in a while, not every semester, but every once in a while, I'll have somebody who's had some formal electrocardiogram training, and that's great. I love that. If you have had formal electrocardiogram training, good on you. But let's dial it back for purposes of this class. Okay. We're not going to diagnose in this class. I am going to give you some exposure to arrhythmias and what you should be looking for and that sort of a thing. But since this is not a certified EKG or ECG training class, I want to emphasize, and any person who's interpreting or looking at electrocardiograms or is involved with electrocardiograms as a patient or as caregiver should understand these basic concepts about what people are really looking for in an electrocardiogram. If we are not looking for specific diagnosis at the very beginning, we want to ask ourselves what it makes this either a normal tracing or what makes it an abnormal tracing. And there are 4 fundamental questions. There are some other questions out there, and again, you can get granular with this. And many of you will want to get granular with this, but keep it right here with these 1, 2, 3, 4 questions, okay? I will probably ask you on an exam to look at an electrocardiogram and say, is this normal, is this abnormal, and why? And the why will fall into one of these 4 questions. Okay, a common mistake that people will make on an exam is they'll start to talk about all these little things and thises and that's when they have completely ignored the 4 fundamental questions. Okay, the 4 fundamental questions. You start here. Okay. First of all, what is the rate? Even a normal sinus rhythm, if it is too fast or too slow, is an arrhythmia. If it is too slow, we call that bradycardia, and you're at risk of disorderly contraction in the heart if the heart gets too slow. If the heart gets too fast, you also have an issue with heart failure, because if you're trying to initiate another beat while one is still occurring, that would then fall into the refractory period, and again, loss of regulated contraction. So the normal range is somewhere between 60 and 100. Now, many people who are very, in shape and working out will see a resting heart rate below 60. That's very common. In fact, a former Tour de France champion, his name was Miguel Indurain, who also won the hour has the hour record. So they ride their bike for an hour and see how far they go, and he just destroyed it. He has a resting heart rate when he's sleeping like in the 40s or 30, something ridiculously slow. In any case, the normal is 60 to 100. Anything above that, you're starting to getting scary when you're talking about resting heart rate. The heart does change its activity based on the signals that it receives from the body, including sympathetic and parasympathetic signals. So if the body is stressed out, if there's an increased metabolic need, that heart's going to accelerate. So if somebody's sitting around and their heart rate's at 90, 100, that's a very big red flag. Okay? So rate is the first fundamental question. How do you determine rate? There's a very simple way of doing this. Count the number of boxes. Okay, in this case, it's 1, 2, 3, 4. You can divide that into 300. That would give you 75. So 300 divided by 4, 75. 300 divided by 5, 1, 2, 3, 4, 5, would be 60 beats per minute. So if you're just looking at a tracing, see if you can't spot 5 beats. Okay. See if you can't, and okay, let's do this one. 300 divided by 1, 2, 3 would be 100. So the normal distance, 1, 2, 3. So the normal range in terms of rate would be between here at the third line and here at the fifth line. Okay, that's the normal range between 3 boxes and 5 boxes. Pretty easy. Okay, you can calculate exact rate. Just take the number of large boxes divided by 4. You can even approximate. Is it 4.5? Okay, you can do that. Simple math. Okay. The next thing is called regularity. Is the rhythm regular? And you can use a really high-tech piece of equipment to do this. Basically, a sheet of paper and a pencil. And what you do is you go along and you mark where you see 2 R waves. And then you can slide it along this tracing and see if you see any discrepancies. Let's try this one up at the top. I can't do it very well with this pointer, but you can count 1, 2, 3, 4 boxes. We have an R wave, so 4 boxes between the R waves. And let's go to the next one. 1, 2, 3, 4. So this would be a regular rhythm. If you see a more than, 1 box either direction, that's starting to imply that the rhythm is irregular. Again, it's with this limited interaction that we have here, that's going to be harder to illustrate. I usually do that on the board or something along those lines. Little shifts back and forth, say within 1 box, one of these large boxes, is perfectly normal. In fact, that happens when you inhale and exhale. You get a sort of what's called a pulsus paradoxus effect. You have a baroreceptor. And what happens is when you inhale, your heart rate will change. When you exhale, your heart rate will change. You can actually experiment with that. Try that sometime. Just exhale and feel how your heart rate changes. That's very normal. But it's usually within 1 box either or. If you're outside of 1 box either or, that is definitely irregular. Are all the normal waves? And that's a tricky question. Like, for instance, look at this one up here again. And look at this one down here. You can see they're not identical, right? Do you see a Q and an S wave in any of these QRS complexes? No. Okay, so don't get too granular. What we're looking for is P, R, and T most of the time. So we've got a P wave, we've got an R, and a T. P, QRS, T. P, QRS, T. I say R wave here, but you can infer the Q and the S's are there. So this is a normal rhythm in terms of the fact that we see all the normal waves. You don't always see Q and S, but you do see P, R, and T. Lastly, do you see a 1-to-1 ratio? Is there a P wave for every QRS and T? P wave for every QRS and T? P wave for every QRS. And yeah, the tracing ends here. We can infer that the T's there. We're seeing a 1-to-1 ratio. PR segment constant. Let's hang on a second. Let's strike that out. I'm not going to worry about PR segment constant and length. Yeah, there are some issues there. This has to do with AV node. So we get this depolarization of the P wave and you hit the AV node, and is there a delay there? If you have an issue with the AV node, you would start to see variable PR segment or extended PR segment situations. We're not going to worry about that right now. Let's keep it basic with the first four here. Rate, regularity, do you see all the waves present, and is it a 1-to-1 ratio? Let's digest ratio just a little bit more, and here's another little secret. Again, it's 300 divided by the number of blocks. That's easy, but you can also, if you had to, you could memorize. So for instance, 60 beats per minute, 1 beat for every second is 1, 2, 3, 4, 5 blocks. Okay. If we're at 50 beats per minute, that would be 6 blocks. 1, 2, 3, 4, 5, 6. 1, 2, 3, 4, 5, 6. So that's the 300 divided by 6 would be 50. 300 divided by 4, 75. 300 divided by 3, 100. 300 divided by 2, 150. And 300 divided by 1, 300. Dangerous rhythm right there. Anything above 180 is starting to get into the red zone, if you know what I mean. Anything below 50 also starting to get into the red zone. The standard rate would be somewhere between 5 blocks and 3 blocks with a plus or minus 1 variability during breathing or that sort of a thing. So we might see this, let's start with this guy as a reference. Maybe we have a little faster beat and so it slides over a little bit left, or maybe we have a little bit slower beat, slides a little bit to the right, but you should be within about a box or so on either side of the average rate. If we start to see more than that deviation, now we're getting irregular. So let's look at some examples here. Let's look at normal and abnormal electrocardiograms. Normal electrocardiograms, a little small, I know. P, yeah, you can see the Q's and S's. QRS, T, P, QRS, T. Is it regular? 1, 2, 3, 4. So that's a 75 beat per minute. 1, 2, 3, 4. Yeah, 75. 1, 2, 3. Yep, 75. You can see that you don't see a lot of deviation here. It almost, I don't think they introduced any variability on this. I think this was artificially, generated. In any case, you see the 1-to-1 ratio. It's regular. It's the right rate. All the waves are present. All 4 criteria are satisfied. Let's move now to number 2 here. And again, don't look at the diagnosis, or now you just did. But in any case, I want you to notice something. P, P, QRS, P, 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 QRS, P. What's going on is that you can see that the P wave is actually very regular. It's just firing off about every, looks like 1, 2, 3. So it's firing off at around 100 beats per minute. Okay. Your P is probably hiding in this one here, but you can see that P is just firing off like it's just doing its thing. Well, look at the QRSs. You see there's a 1-to-1 ratio discrepancy here. There should be a QRS here and a QRS here. We got one, but not here and not here and not here. The QRS is firing off, and you see, okay, how many boxes in between? 1, 2, 3, 4, 5, 6, 7, 8. Okay, 300 divided by 8 is somewhere in the 30s. Okay, if you just kind of estimate a little, maybe somewhere in between 30 and 40. What you have going on here, they call this a 3rd degree block. What's going on is that the P waves are firing, so the atria is doing its thing, but the signal is not getting to the ventricles. And so the ventricles are firing off at their own tempo. That's that autorhythmicity that I was telling you about earlier on in this chapter. So the P waves are doing its thing. The the ventricle is firing off because it's not receiving signal from the atria, and it's firing off at its intrinsic depolarization rate. They call it third-degree block because now the atria and the ventricles are not talking to each other. There is something wrong with the AV node. There is something wrong with the conduction of signal down into the ventricles. And so the ventricle autorhythmicity kicks in. Number 3 here, what we see QRSs, and you see this kind of thing going on. And look at how variable the QRSs are. Here's a fairly normal width, fairly normal. And look how shallow, quick that one. Then it's a little longer. Then it's back to medium, then a little shorter, then a little longer, then really long. This is irregular. Okay? Even if you did imagine seeing a P wave and a T wave here, and you can kind of do, I kind of see one there. But it's hard to discriminate. What you have is this sort of unstable baseline. This is called atrial fibrillation. Atrial fibrillation is very, very common arrhythmia. That's because the atrial tissue does tend to be vulnerable to certain types of disorders, either mild infarcts or things along those lines. It tends to be sort of a canary in a coal mine, and AFib is very, very common. So, and people can function just fine, but it is an abnormal rhythm by virtue of the fact that you can't see the P wave, you can't really see a T wave. It's irregular, all right? The rate is also changing a lot. So like for instance, these two guys, that's pretty fast. That's faster than a normal resting heart rate. So there are at least 3 different criteria that you could establish this to be an irregular rhythm. Ventricular fibrillation, this is where we don't see any P waves, and what we see is a wave that is dominated by ventricular function. So the ventricles are hiding all the other possible waves in this, and this is clearly abnormal. This is one you wouldn't mind seeing if you happen to have somebody in cardiac arrest. It means the heart is still viable. I'll talk about that a little bit later, just more for your own, your own purposes when you get out into the healthcare world. And for fun, why don't you give this one a try? Give that one a try and see if you can come up with normal or abnormal. Just one criteria is enough. You see, check to see that you have a rate. Check to see if it's regular. Are all the waves present, and are they all present in 1-to-1 ratios? Good luck. Here's some common arrhythmias. These are ones that you see a lot, and I just want to give you some background on this, just in order to tell you where the next level goes, and when you're out there and you're dealing with patients who have cardiac issues. By the way, speaking of cardiac issues, this whole hydrochloroquine and azithromycin, you're going to see some cardiac issues from that, I guarantee you, because that is well known to cause issues with QT interval. It's well established. So especially with people making a mad dash for hydrochloroquine, eating, fish tank cleaners and all kinds of fun stuff. But that's aside the point. This one's a real common one, and you'll often see it in somebody who is otherwise asymptomatic, and they might not even know they get it. They just happen to see it when they get hooked up to an electrocardiogram. And this is called a PVC, a pre-ventricular contraction. You hear that phrase? Pre-ventricular contraction. What's going on is that the ventricle is spontaneously depolarizing and squeezing. It's uncoordinated, which is why you get this big wide thing like this as opposed to a nice regulated rhythm. Oftentimes people will kind of notice it. They might feel it from time to time. It just kind of feels a little bit weird. But PVCs are in and of themselves not diagnostic. It may mean that there's some irregularity there. It's a yellow flag. It just says, hey, we might look a little closer, but it's not necessarily the sign of, it's not necessarily diagnostic, shall we say. Yes, it is an arrhythmia, but it is not necessarily diagnostic. Here's AFib again. Atrial fibrillation. This is a little bit better one. Yeah, there's a little T wave there. You can see it right there and right there and right there. Maybe even a little one there. But you can see that P wave is erratic. What's going on is that you're getting spontaneous depolarization in areas of the atria that are leading to disordered rhythm. And every once in a while, one manages to fire off the AV node, and you get a QRS. So we've got 1, 2, 3 boxes, 150 rhythm here. or 100 rhythm, excuse me. Then the next one, look at this, 1, 2, 3, almost 4 boxes. 1, 2, 3, 4, 5, almost 6 boxes. So if nothing else, you could say it's abnormal because it's irregular. Okay? This one's abnormal because you don't see a P and a T with that QRS, so that would be considered abnormal. This one would be abnormal by virtue that you can't really see a clear P wave. Okay? But it's the big one is the regularity. Last one here, we see, you can see a P wave right here. It's almost overlapping with the T. See, there's a T wave, and then the P wave is just hiding there. You just got a little one hiding right there. Okay, so we see a P, QRS, and a T, P, QRS, and a T. Okay, that's fine. So we have 1-to-1 ratio. It looks nice and regular. Okay. But what about the rate? Okay, so let's see here. 1 box, 2 boxes. Oh my gosh, this is a resting heart rate of 150. Okay, this is sinus tachycardia. Somebody who has a resting heart rate of 150 is under a lot of duress, metabolic duress or sympathetic duress of some kind. So again, a dangerously fast, especially when you're talking about a resting heart rate right here. But you have that 1-to-1 ratio, you have the regularity, you can see all the waves are present. The issue is rate. Okay, so these are some common arrhythmias that we see. And let me do one more panel on this, and then we'll move on. So what makes this arrhythmia abnormal? So we have 1, 2, 3, 3.5. It's just in the 100. So it's normal in terms of its rate. We see a PQRST, and it's a 1-to-1 ratio. Okay. PQ, it's a little bit weird there. Okay, we're missing one there. So I guess by default you would say that that's abnormal because the P wave is sort of weird here. But the fun part here is qualitative. This is not a super common arrhythmia, but it was something that one of our professors in the department had, who's now retired. This is a bundle branch block, and I use this example to show you a manifestation that associates with a structure that you should be familiar with. When you have that AV node fire off after the delay, it goes down the bundle of His, and then it splits down into 2 bundle branches. And if one of those bundle branches is not conducting the electrical signal properly, it will show up as a separate peak. So we have one bundle branch and then the other one. So there's a problem, and you can see it's consistent. One branch is doing just fine. The other one has a partial block. It's not conducting as rapidly. And that's why that QRS complex is a little bit wider, okay? But it also has this forked tongue. A lot of the time, these bundle branches, you'll actually see 2 peaks that are the same height, but the QRS is much wider. But this is the nice example of a rhythm where you can equate a malfunction in a specific structure with a rhythm on the electrocardiogram. Shockable arrhythmias. So many of you will undergo defibrillator training, even automated defibrillator training. What we see is that we have different kinds of arrhythmias that the auto defibrillator or somebody who has an auto pacemaker, an auto defibrillator inside their chest, or if you're trained with a manual defibrillator, you're going to be looking for. This is the one you hope for. If you have somebody who's in cardiac arrest or a near cardiac arrest, or they have a very rapid thready pulse, and you hook them up to the electrocardiogram or you hook them up to the defibrillator, this is the best rhythm you can hope for. This is called ventricular tachycardia. So look at the shape here. It's a ventricular rhythm. You don't see a P and a T wave. What you see is all ventricular. But what you have is this really nice, relatively regular rhythm. It's very regular. Yeah, it's fast. Yeah, it's got a weird shape, but this is a good, strong heart. This is a good, strong heart that has just gotten out of whack. The signaling has gotten screwed up. This is what we call a re-entry rhythm if we were getting to an advanced class. What's happening is that in the heart, the depolarization is cycling back on itself. There's a possibility for what we call re-entry, where you get a depolarization on one side and it swings around and it causes continual depolarization, re-entry. Again, I'm not going to test you on that, but this is the rhythm you dream about if you're going to give somebody a defibrillation shock, because the heart's nice and healthy, or relatively speaking anyway. A little bit less ideal prognosis would be ventricular fibrillation. You can see that it's more irregular. It's not as nice, not as much vertical displacement. The waves are a little bit less symmetrical and so forth. Still a shockable rhythm, by the way. You see this is another one that if you're using a manual defibrillator, you have to go ahead to give them what we call a cardioversion. This right here, this is complete asystole, sometimes known as a flat line. This is not a shockable rhythm under normal protocols. Under normal protocols, that is not a shockable rhythm. But you know what happens in the field? Somebody goes, oh, I think I see a little deflection there, and they shock them anyway, because what's really the harm? You can actually give cardioversion to somebody with a beating heart. It's not that big of a deal. You want to be careful about it. You don't want to do it just willy-nilly. But there are people who have a sort of a progressive arrhythmia, and so what they'll do is they'll go into the clinic and have a cardioversion done in order to restore the normal rhythm. So they call that cardioversion. That's basically just hit them up with a couple of defibrillator paddles. People sometimes have internal pacemakers and internal defibrillators. Former Vice President Dick Cheney has one, and he says when it goes off, it's like a kick in the chest. Okay, it goes off, and and he's not given warning, if you know what I mean. In the final 8 or 9 slides here, I'm going to put all of the pieces together in terms of electrical, physical, and now volume activity. We have some volumetric terms that we're going to bring into play, and I'm going to start talking about pressure a little bit and so forth. So let's get started in the cardiac cycle. Let's begin at the 12 o'clock position with the period known as late diastole. Late diastole is when all the chambers of the heart are in a relaxed state. It also means that the pressure in those chambers is lower than the pressure of the inflowing veins. Blood or liquid does not flow unless there is a pressure gradient. So in order for blood to flow into these chambers, the pressure has to be lower than the pressure in the arteries. So this very, very low pressure at this time. This is about when you have 80 to 85, maybe 90% of the ventricular volume delivered to the ventricles. So that's called late diastole. The first thing that happens is we get that P wave. We get a atrial depolarization, not shown here. And then we get atrial systole, starting from the base, squeezing towards the apex. This atrial systole is an ejection of blood from the atria, and they say small amount here. We're only talking about 10, 15 or so % of the total ventricular volume is inserted during atrial systole. After atrial systole, we have the ventricular depolarization, and then we have the onset of contraction here. That onset of contraction starts here at what's defined as S1. S1 is sound. So that sound is caused by turbulence in the valves. And so when those AV valves shut, there is a bit of turbulence there, and that is sound 1. So at the onset of sound 1 is the beginning of when the pressure is rising to the point that those valves close. Okay? The pressure is rising, but the volume is not diminishing. The pressure is rising, but the volume is not diminishing. This is why it is isovolumic. You might say isovolumetric as well, but in this case it's isovolumic. What's happening is the pressure is rising inside the ventricles, but the blood is not moving. Why is that? Because the pressure inside the heart, inside the ventricles, is not higher than the pressure found in those outflowing vessels. Okay? So we're building up pressure, but we are not changing volume. It starts when the AV valves close. Okay. And then when pressure exceeds the outflowing arteries, there's one here's the aorta and here's the pulmonary artery. When the pressure in these chambers is higher than the ambient pressure in those outflowing arteries, that's when we get ventricular ejection. So we have pressure and we now have diminishing volume. Notice that this is not associated with a sound at this point. So we had a sound here at the onset of ventricular systole, that's isovolumic ventricular contraction. When the pressure exceeds the outflowing arteries, we get ejection. And then at the end, when the pressure begins to drop, the onset of ventricular diastole, we get the second sound. And the second sound is the closing of those semilunar valves. The pressure now has dropped below the ambient pressure of those outflowing arteries, and so those valves close, and that's sound 2. But we're still a higher pressure at this point than we are with the inflowing veins. The inflowing veins can't receive blood because, especially the ventricles can't receive the blood because they're still too high in pressure. They have to relax and relax and relax to the point that the pressure is now lower than the inflowing veins, and then they can begin to fill again. So isovolumic ventricular relaxation means that the ventricles are beginning to relax, but there's no change in volume because the blood's not flowing in. The semilunar valves herald that beginning, because when the semilunar valves close, that means that pressure in the ventricles has dropped below the outflowing arteries. But we yet have as yet any blood to come in from the atria or the inflowing veins because the pressure is still too high. That's early diastole. Late diastole, the pressure is low enough and we begin filling again. Very detailed slide there. Very detailed set of slides. Make sure you work through. You're starting to bring multiple events into one picture. This diastole here, you can see late diastole when both the ventricle and the atria are relaxed. Early diastole, late diastole. Atrial systole, ventricular systole. In any case, volume, pressure, contraction, or relaxation. A few minutes back, I mentioned about the heart sounds. The heart sounds can be a very, very important diagnostic tool along with electrocardiogram, and we use what is a technique known as auscultation, where we listen to the sounds generated by the heart in various locations. The standard procedure is stethoscope, but it actually took a few years for the stethoscope to be developed. Prior to the widespread use of the stethoscope, the normal practice was to put the ear directly on the chest. So the first heart sound, we call it the lub, if you will, starts with the closing of the atrioventricular valves, the tricuspid on the right and the mitral on the left, or the bicuspid on the left. That's the onset of ventricular systole. That's also the beginning of isovolumic ventricular contraction. The second heart sound is at the onset of ventricular diastole, and it's caused by the closing of the semilunar valves. And they say vibrations here because what's happening is as the valves shut, you get this little bit of vacuum created. They call it's turbulence, where there's vacuum and then the blood sort of smacks back to close those vacuum bubbles, and that's what those vibrations are, and that's the DUP. The second heart sound is the closing of the semilunar valves at the onset of ventricular diastole, isovolumic ventricular relaxation. And for some fun, check out the Stanford 25 sometime. Really, really cool. It was developed by a professor of medicine named Abraham Verghese, and he's trying to bring basic techniques back to the clinical setting. We're far too reliant on machines. We're far too reliant on diagnostics. and he's trying to bring it back. It's an absolutely fascinating set of things. If you're interested in primary care at any level, the Stanford 25 is a wonderful reference for you. And they actually show you that it's actually not two different sounds. They can actually have up to 4 different sounds, and there's some fine tuning here, and you can see some unusual patterns occurring with certain types of valve and heart issues. Last major slide in this presentation, and it's a big one. This is super duper important. Get to know this figure and get to know what it means. Okay, it's not enough to be able to regurg on this one. You need to be able to understand what this figure is trying to show you. It's showing you the electrical activity. It is showing you the pressures in various chambers, the left atria, left ventricle, and the aorta. It is showing you the sounds here, and it is showing you the volume of blood present in the ventricle at any given time in the cardiac cycle, all on the same x-axis. This is known as the Wigger's diagram. I've mentioned this a few times. We've seen figures sort of like this in the past. Figure interpretation is a major, major clinical skill. So I include this as a way to help bring all the material that we've talked about together and to help reinforce this idea that you need to be able to interpret figures. You will look at it, figure out what's going on, and derive meaning from it. So at the top we have our P wave. Notice that we don't really see a whole lot of rise going on, except we see a bump in the atrial pressure. That's because the onset of atrial contraction on the back half of that P wave during that sort of PR segment. We have the QRS complex, and what you see is at the middle, somewhere in the middle late QRS, we begin to see this red line spike up, and that's ventricular pressure here. When ventricular pressure exceeds the aortic pressure, what do we see? We see them match up. That's when we see ejection going on. So here at E, what we see is a diminishment in volume. That's because we are sending blood into the aorta. Notice something else here, and I'm bouncing around a little bit. I'm sorry about that. But here during atrial systole, we see that we've got volume here, and then we get just a little bump. Let's slide over here to F for a second. During late diastole, we're filling with blood, and then we have another atrial systole here. We have just a little bump in volume. So that atrial contraction is just delivering only a little bit of volume to the ventricles. We get that isovolumic. See, it's the volume's not changing, but the pressure is rising. So we know that the ventricles are contracting. We have a sound there, the valve's closing. So the ventricles are contracting by virtue of the pressure rising, but the volume isn't dropping. That's isovolumic ventricular contraction. Once we exceed the aortic pressure, then we see ejection. Then we have this period of time where the volume doesn't rise again. The pressure is falling. It's fallen below the aorta. So we have that second sound here. The pressure in the heart is falling below the aorta. But notice the blue line is way down here. That blue line means that the pressure at this period of time is still higher than the inflowing atria. So we're not going to get blood flow into the ventricles, so no filling. It's only here at point D that we get filling again. So it's not until the ventricle drops below the atrial pressure that we begin to see a rise in pressure. So point A, what we have is at the end of isovolumic ventricular contraction, and we're seeing ejection going on by virtue of the volume dropping here. The pressures are fairly well matched here. At B, this is when the pressure of the ventricles drops below the aorta. We get that sound there, and we see falling pressure, but we don't see rising volume. At point C, what we have here, this is when we have the closing of this valve. Point C is a little bit out of place as far as I'm concerned in terms of logic, but that's neither here nor there. When the ventricular pressure rises above the atrial, that AV valve has to close, and that's why the sound is right there. Point D, that's where we have the ventricular pressure dropping below the atria, and we begin to see filling here at point F. Point D and point F are at the same basic point in time. It's just that point F is emphasizing that we're beginning to fill here. D is emphasizing that we've dropped below the atrial pressure. So there's a lot going on here. And there's one more little thing I want to show you here. You see this little bump? Look what's happening. Aortic pressure drops along with the ventricular pressure, and then ventricular pressure keeps dropping, and then this weird thing happens. The pressure starts rising again. And how is that possible? How is that possible? The heart's in relaxation. How can blood pressure rise if the heart is relaxing? That doesn't make any sense. Well, it makes sense if you understand vascular function. The role of the arteries is actually to sustain pressure in those arteries. Again, if you don't have flow, or you don't have pressure gradient, you don't have flow. So what this rise here, this increase in pressure, is due to contraction of the aorta. Contraction of the aorta and the large vessels is causing that pressure rise. And that's also why pressure stays high in the aorta, is because the aorta has actually got smooth muscle and it's squeezing in order to sustain pressure. Well, that's in the next chapter, but I want to point that dicrotic notch out. We usually do a lab where we look at dicrotic notch, and I don't think we're going to be able to do it now that COVID has taken over. But for our purposes, I just want to point that out. Pretty cool that the blood pressure would actually rise even though the heart is relaxing and falling in pressure. Here's a nice link for you if you want to look at the Wigger's diagram a little bit more. I can't emphasize it enough. I will tell you right now, there will be a Wigger's diagram on the exam, so it would be a good idea to be able to ascertain meaning, be able to explain what's going on in parts of the Wigger's diagram, because there will be questions about it on the exam. And again, we have a nice link here, maybe even some tutorials for you to show you the different terms that we've talked about in the past. When are the ventricles filling? When are the ventricles ejecting? When do we see? Here's that dicrotic notch again right here. Okay, things along those lines. We see sounds and so forth. So this is a really, really nice resource for you. A little bit longer lesson today. Sorry it went a little long, a lot going on, but it's the last one for Chapter 14. So thank you for your time, and hit me up if you have any questions. I'm online as much as possible. You can text me, let me know, and I'll join the Meet group, and we can talk then. Thanks again, and I'll see you soon.